Hello and welcome to Season 2, Episode 31 of the Physician Assistant Exam Review Podcast. This week we continue with thyroid disorders. My name is Brian Wallace. I'm the host and creator here at physicianassistantexamreview.com. Over at the website, you can find all of the notes for everything that we cover here, as well as all of the back podcasts. I know some of them have been dropping out of the podcast feed, and you can find them over on the website. So today what we're going to be covering is we're going to continue with the endocrine system, and we're going to continue with the thyroid in particular. Last week, we covered hypo and hyperthyroid. We covered thyroid storms. And this week, we're going to move into thyroiditis and thyroid cancers. It's been an exciting week over at Physician Assistant Exam Review. We launched the Physician Assistant Exam Scholars newsletter. The very first issue went out today. I'm super excited about that and how well it went, how well it received it was. I could not be more excited about sharing just so much stuff, so much information about study skills, I'm looking forward to working on getting your first job, on all sorts of on doing well at rotations, on being better prepared for your interviews, for so many things that I wanted to be able to share and have time to do. And the newsletter seems like it's really going to be the place where I'm going to do that and start bringing more of the community together there as I move forward. So this was month one that launched. This is, April 27, 2018. And like I said, I could not be more thrilled with how that's going. So some very exciting things going on over here. Oh, also, speaking of exciting things, this is I'm recording this Monday, so just before the basketball game. And Tuesday, this will go out live. It'll be, not live, obviously. I'm recording it now. It'll be launched out to the world on Tuesday morning. On Wednesday, Andrew from MedGeeks has offered to put together a package for our community over here, which is great. I've been in touch with him since he started out, about 5-6 years out into doing his podcast and producing his materials, and they've been great. We've sort of followed each other's paths and been back and forth and sort of follow what each other does, and we've talked here and there and sort of helped each other out. And he has put together a really sweet package for you guys. That'll go out. I'm going to put that out, all the information there in the email list, but it'll go out on Wednesday. But it's a one-day only kind of thing. So if you catch this on Tuesday morning, definitely pay attention on Wednesday when I'm going to show you what he has put together for you guys just for that one day, just for this coming Wednesday. That'll be April, what's today? Today is the 2nd. This is being recorded. It'll go out on the 3rd. It'll be April 4th that I'll put out the information on that package he has. So keep your eyes peeled for that. All right, so like I said, some exciting things, but let's go ahead and move on and jump into our priming questions for the thyroid. So I wanted to start with just a review from the last episode. Where is TSH created? Where is TSH created? Next, we have what is the most common cause of hyperthyroidism? What is the most common cause of hyperthyroidism? And then one to get you primed for this week, name the 4 general types of thyroid cancer. Name the 4 general types of thyroid cancer. All right, then we're going to jump in with thyroiditis, which is very simply an inflammation of the thyroid. Like I said last episode, I wanted to cover this as part of hyper and hypothyroid, but it didn't really. I wanted to cover it before that, and after it, it's kind of cyclical. But the reality is, it sort of comes after it. This inflammation of the thyroid, there are several different types, and all of them pretty much can cause hyper and hypothyroid. Or in fact, they usually do. It just depends on when in the series you catch them. So let me run through a few of the types, because especially if you're driving or you're doing something else, you're exercising, you're not going to be able to hold on to this if I just run through it once. So I'm going to go through it a couple times here so you can use the idea, so you can have a picture of them as we go through. So the first one is Hashimoto's thyroiditis. This is also known as chronic lymphocytic thyroiditis. Then we have subacute thyroiditis, also known as granulomatous thyroiditis or de Quervain's thyroiditis, and giant cell thyroiditis. This is thought to be caused by a virus. Postpartum thyroiditis. This is believed to be an autoimmune issue and occurs in 7.2% of women post-delivery. I was shocked at that number. 7.2, that's a real number. Then we have Riedel thyroiditis. This is an invasive, fibrous, woody. That's sort of how it gets described, and it often goes along with systemic fibrosis, and it's the rarest form of thyroiditis. So let's go through those in just a little bit more detail. I'm not going to do a ton of detail here. I don't think it's entirely necessary. I need you to understand that thyroiditis is an issue. The thyroid can get inflamed, and it can either cause it to go into a state of hyperthyroid or hypothyroid, depending on what's going on, and have a little bit of understanding and clarity when it comes to these, but I don't think a ton of detail is necessary. Hashimoto's thyroiditis, this is also known as chronic lymphocytic thyroiditis. Most of these patients have symptoms of hypothyroidism, but some will have symptoms of hyperthyroidism. So if you're going to get asked a test question, it's going to be a hypothyroid kind of situation with Hashimoto's. Patients have a high rate of other autoimmune diseases, and this is where this differentiates itself from the other thyroiditis. It has that multiple autoimmune issues. So you get Hashimoto's thyroiditis, but you also get things like Sjogren's, myasthenia gravis, celiac disease, and Addison's disease. So pay attention to those pairings. That's what's going to make this one stand out. On clinical presentation, the thyroid may be enlarged, firm, rubbery, nodular, or smooth, and generally speaking, it's non-tender. And the patients may come in complaining of neck or throat tightness, because you can definitely get an enlarged thyroid, and that's where that's going to come from. You can get mental changes like depression or chronic fatigue. And again, so the symptoms or the presentation is going to be very like hyper or hypothyroid, right? So I could list all those all over again, but that doesn't make a lot of sense. That's not really going to be how you're going to be able to differentiate these. So yes, I can get some depression or chronic fatigue. That goes along with your hypothyroidism, right? So a lot of those symptoms will be similar. Labs and studies, same thing. So we're going to check for T4, TSH, thyroid antibody, iodine uptake, and you're going to look at all those things, right? But it sort of depends on where you are in the stage and what's going on, whether they're elevated or not. But you're obviously going to be getting them and using those to create your whole picture. You're also going to do a fine needle aspiration. You're going to be, because you're concerned about risk factors for cancer, but for all of these, it probably makes some sense to go ahead and do that. Treatment is going to be hormone replacement. Again, we're saying that most of these will present as hypothyroid, so you're going to do levothyroxine for your hormone replacement. Subacute thyroiditis is our next one. This is also known as granulomatous thyroiditis, de Quervain's thyroiditis, and giant cell thyroiditis. This is thought to be caused by a virus, and 50% will have thyrotoxicosis followed by a hypothyroid, followed by euthyroid. So it changes as time goes by. So again, the labs are very useful, but you're not going to get a question that's going to say, TSH is elevated, T4 is down. Which thyroiditis is it? It depends on the when in the cycle. Clinical presentation here, they can have acute pain that radiates to the jaw and causes difficulty swallowing. Painless is known as silent thyroiditis if they don't have any pain. The thyroid can be tender, enlarged, and firm. And they may have a low-grade fever. Again, think about this from the idea that it's an infection, right? That they think it's a viral infection. It swells, it gets enlarged, you get some pain, and you get a fever. That sort of makes sense if you package that all together. Labs are going to be the same: T4, TSH, thyroid antibody, iodine uptake, and fine needle aspiration, and perhaps an ultrasound. We can include that in most of these as well. Treatments are going to be, again, we have a viral infection that's causing some issues that may result in hyperthyroid or perhaps even hypothyroid, depending on where we're at. So you're going to use NSAIDs, corticosteroids, beta blockers, and this is a self-limiting disease. So we're not really treating the disease per se. We're treating the symptoms of the thyroid. Postpartum thyroiditis. This again can be hypothyroid or hyperthyroid, and it occurs in 4 to 7% of women in the first 6 months after delivery. Usually, so 1 to 6 months postpartum. And again, that's a real number, 4 to 7%. I just didn't realize it was that big. I guess I should have from the first time I went through these notes, because the numbers haven't changed, but it still is just surprising that it's that high. Often this is painless. Same labs and studies, so T4, TSH, thyroid antibody, iodine uptake, all those things. Treatment is going to be symptomatic and supportive, and again, it's self-limiting. Our last one and our most rare exhibit of thyroiditis is Riedel thyroiditis. I think that's how you pronounce it. It's a systemic disease characterized by fibrosis and IgG4 secreting plasma cells. This is extremely rare. On clinical presentation, you get hypothyroid symptoms. The thyroid becomes enlarged and hard. You can get dysphagia, hoarseness, pain, dyspnea, and typically goes along with systemic fibrosis, which we've said a couple times now. I just seem to have it in my notes more than once. Labs and studies. Blood work, again, same stuff. Thyroid, TSH, T4, thyroid antibody. You might get a SED rate. The other one they included here, actually that goes... Nah, I'm just going to skip through that. I don't want you to have too much to hold on to for these. I just think it doesn't make a lot of sense. So you can ultrasound to distinguish thyroiditis from nodular goiter or possible malignancies. And again, the radioiodine uptake and a fine needle aspiration, because that's really going to give us our determination about thyroid cancer, and you're going to want to be prepared for that. Treatments for this are going to be, you may need surgery to remove the thyroid, but the medical treatments are going to be prednisone. And again, you think about that fibrosis, you're going to need prednisone is going to get that under control. And then tamoxifen is another one that's going to help get this under control. Let's move along to thyroid cancers. The answer to our question, what are the 4 general types of thyroid cancer? Papillary, follicular, medullary, and anaplastic. We'll start with papillary carcinoma. And if you remember them in that order, basically they go from most common to least common, and also from least worrisome to most worrisome, I guess is a good way to put it. Papillary carcinoma is the most common. It's about 80 to 90% of thyroid cancers. It affects females about 3 to 1 times more than males. So that's an important one. And the reason why it's important is because when you get to a test question, you need to be able to, in the back of your head, in the back of your mind, you need to understand that these questions will be worded as a 45-year-old female comes in with XYZ. They don't just randomly choose a 45-year-old female. It also happens that this is most commonly found in 30 to 60-year-olds, right? So they're probably going to pick someone in that range, and they're probably going to pick a female just to give you more clues. Now, they could pick a 75-year-old obese male, but it's unlikely. They're probably going to give you the most likely candidate for this. So I would hold on to things like females are more affected by papillary carcinoma. People more affected are 30 to 60 years old. In fact, in my head, I hold on to the fact that all thyroid issues are female issues. Now, that doesn't necessarily mean it's true. It doesn't mean it holds for each and every one of them, but I can't remember each diagnosis and which one is weighted more heavily towards females and which ones aren't. So for me, for my exam, again, I think it makes the most sense and it's easiest to create that picture in my head of what each disease looks like. And for this one, it's definitely a female disease in my head. And that makes it easier to answer questions when I see them. This is the least aggressive thyroid malignancy. It's slow growing, but it will move to regional lymph nodes. Childhood head and neck radiation increases your lifelong risk of this. You're going to want to do an MRI, ultrasound, and finally a fine needle aspiration to diagnose this. You're going to get a T4 and a TSH, and treatment consists of total thyroidectomy and radioactive iodine ablation of any remaining tissue. It's hard to see all of the thyroid when you're in there. I do some ENT at work. For those of you who don't know my backstory, I work in the operating room 5 days a week. I'm a first assistant at a small community hospital, and I do all different subspecialties. We do ENT, we do plastics, we do spine, we do, what else do we do? We do C-sections, robotic cases, GYN, all kinds of stuff. And like I said, one of those things is ENT and taking out thyroids. One of the interesting things about doing surgery is that, there's no dotted line. The thyroid's not colored bright orange and the rest of the tissue around it is plain white. You can tell the tissue to some degree, but you can't see it all. It's not as super clear. When I used to do foot and ankle, we used to do a lot of osteomyelitis, which is infected bone. And what you would do is you would go in and clean out the bone. You'd take basically a sharp pair of pliers is the best way I can describe it, called a rongeur, and you would bite out this infected bone, but there's no clean lines that tell you this bone's infected, this bone isn't. It's a judgment call. You take out as much as what looks kind of infected or looks like thyroid tissue, and again, you can tell most of it, but at some point, it's hard to tell the difference, and you may leave some behind. So if you leave some thyroid tissue behind, which you know you did. You do a radioactive iodine to ablate what's left. And the same thing with osteomyelitis. You don't just not give antibiotics because you assume you got it all. You run in antibiotics to make sure you got everything, or and if you didn't, to cover what you didn't get. Follicular thyroid cancer. This is 10 to 15% of thyroid cancers, more aggressive than papillary cancer, and it may secrete enough T4 to cause a thyroid storm. So that's something you may want to put a little check mark next to. And again, we're going to get an MRI, ultrasound, and a fine needle aspiration. We're going to check T4, TSH, and all the labs we would normally do for a thyroid issue. And again, this same treatment consists of total thyroidectomy and radioactive iodine to ablate any remaining tissue. Next, we have medullary thyroid cancer, which is 3% of thyroid cancers. 1/3 is sporadic, so it means non-familial, just sort of happens. 1/3 is familial, and 1/3 is associated with men type 2, capital MEN. We're not going to go into all the details of that here, but it is worth noting under medullary thyroid cancer. Typically, early metastasis is present with this. One of the major markers for this is the tumor secretes calcitonin, so there's a super high increased level of calcitonin. It actually tends to be so high that the receptors shut down, so it doesn't affect calcium as much as you think it would, but the calcitonin levels will be very high. It may secrete serotonin and prostaglandins, causing flushing and diarrhea. And again, we're going to do a fine needle aspiration, MRI, ultrasound, check for T4, TSH, so the rest of our labs, and then treatment will be a total thyroidectomy and radioactive iodine to ablate any remaining tissue. Our last one is going to be anaplastic, which is only about 2% of thyroid cancers. It's the most aggressive thyroid cancer, rapidly enlarging early metastasis to local and distant sites, typically found in older patients. That's your little note there. Typically a single nodule, 5% of palpable nodules are malignant. Painless neck swelling, may have symptoms of hyperthyroid due to excessive T4 production, including the possibility of a thyroid storm here as well. And you may find metastatic disease in the lungs or in the bones. So again, an MRI, ultrasound, fine needle aspiration, you might do a PET scan because this is more aggressive. T4, TSH, the rest of those labs. And then again, we're going to do a total thyroidectomy and radioactive iodine and then deal with the metastasis as necessary. And that will wrap up the thyroid for us and move us right along through endocrine, which is awesome. So our study tip for today, let's move right into that. Our study tip for today, I was listening to something today that made me laugh and made me think that I should share it with you guys. It's by a guy named Matt Fury. And what he was talking about was some mindset stuff, which is something I think is so important when I look at people and they talk about their test-taking abilities. Some people will come to me and they'll email me and they say, I failed the exam. I'm a terrible test taker. I don't have to, why do we have to do this? Or they just think of themselves as bad test takers and then they go in, they get anxious, they don't do well. And it's such a self-fulfilling prophecy that people present to themselves this idea that, oh, I'm bad at this. So that means they'll never be good at it. And if they want to be right when they say that they're bad at it. So then they follow through and they are bad at it. And the end result is they are bad test takers. When I think a big part of this could be solved by believing in yourself a little bit and going in and saying, I've been taking tests for years. One, it's about time I figure out how to do it. But two, instead of walking into a test telling yourself how bad you are going to do at this, why not walk in and say, this time is going to be different. This time I'm going to do great. It doesn't take anything extra. It doesn't take any extra energy from you. It's not harder. It doesn't change anything. Just walk in, say, I'm going to do great today. Matt Fury was calling this your inner winner versus your inner whiner. And he was talking about in relation to push-ups and getting out and going for a run. That if you go and you're the whole time, I'm so tired. This is so miserable. I can't believe I have to do this. Then yeah, you're going to be tired and miserable. It's sort of the way that it works. Again, it's a self-fulfilling prophecy. But if you go out there and you're like, no, this is going to be great. I'm going to push it. I'm going to do my best. I'm going to do better than last time. Instead of doing 6 push-ups today, I'm going to do 10. You'll find you can do 10. And it's not that hard. It didn't take any more energy. And it makes a huge difference. And I think test taking goes a long way, that it makes a big difference here as well. Because a lot of it is how comfortable your brain is on the day of your exam. It's how well your brain works. And if you're sitting there telling yourself your brain doesn't work that well, you're going to find out that that's true. It doesn't, because you're telling it not to. And I just think that's such a big deal. Zig Ziglar used to call it stinking thinking, And we had to correct that, especially in our children, and make sure that they don't have any stinking thinking. That's something we all should be working on. And like I said, and I'm just surprised how often it makes a tremendous difference, and how often I see people talking themselves down and creating their own self-fulfilling prophecies that they are in fact bad test takers when there's really no reason for it. They could be great, they could be just fine test takers, but they take themselves right out of the game right from the outset. And it's all just in their head. It has nothing to do with their abilities, has nothing to do with their skill level or the knowledge of the information that they have. It has a little bit to do with past performance, but even that isn't really true, because if they were honest with themselves, they wouldn't have come this far had you really, really been a bad test taker. So anyway, that's my study tip for today, is instead of sitting down at your next exam or at your next study session with a dour attitude and saying, geez, I'm a terrible test taker, I'm bad at studying, I can't believe I have to do this, go in there with a whole different mindset and walk through the door with your head high and think to yourself about how today's going to be a new day and how much better this is going to go than it's ever gone before. I think you'll be surprised, at least at how you feel as you move through your exams. Anyway, let's wrap it up for today. Let's return to our questions. Where is TSH created? It's created in the anterior pituitary. What is the most common cause of hyperthyroidism? Graves' disease. Name the 4 general types of thyroid cancer: papillary, follicular, medullary, and anaplastic. Those were our priming questions for today. The other thing I did just want to point out to you again is that Andrew is going to set us up with that amazing one-day package for you guys on Wednesday, April 4th. You can get that. I will put the information on that out through the email list on Wednesday, so make sure you check that early in the morning. If you're not on there, one easy way to do it is to text the number 33444. That's the number to text to, and text the word PA exam, all one word, and that will get you right onto the email list, where you can not only get access to Andrew over at MedGeek's great plan he's put together for us, but also all of the information I send out through the email list. Like I've been saying, it has been my real favorite thing I've been working on for the past 12 months is the email list and the information that goes out through there. I send daily tips, daily techniques, daily ways, mindset issues, things to make you a better practitioner, things to make you a better student, things to make you better on your rotations. All of that comes out through the email list. So I definitely go over and check that out. Thank you to everyone who's been sending in iTunes reviews. Lately, they've been amazing. They've really cheered me up, so I really do appreciate those. So thank you so much. And I think that's it for today. So good luck to you, those of you taking your exam, and I will talk to you soon. Take care.